There we go. Okay. We are being recorded. Welcome to today's COVID-19 Echo on October the 8th. Emily, do you want to do housekeeping?
Good afternoon, good morning, everybody. Today we will not be offering continuing education units, but we hope to start that up again as soon as possible. I'm going to invite everybody to mute yourselves if you haven't done so already, and please feel free to ask questions throughout the presentations. And if everybody could, in the chat, share their tribal nation, tribal entity, intertribal organization affiliation, that would be really great. And that is all I have right now. Thanks.
Thanks, Emily. And we have some good presentations today. We have Imani Ransby giving the updates on the area, USET area. And we have Dr. Mira, who's giving updates on the booster for the vaccine and the monoclonal antibody treatment. So we'll go ahead and get started with Imani. If you want to go ahead and share your screen, Imani.
Thank you, Brian. Good morning, everyone, and happy Friday. Thanks for joining us today. As mentioned, I'll be providing an update on COVID-19 epidemiology for the USET region or National Service Area today. And this update will just consist of reviewing data that's currently featured in our weekly USET aggregate COVID-19 surveillance reports, which focus on COVID-19 cases and vaccine administration within counties and states in the USET region, as well as in the United States. I believe that most are aware, but just a reminder that we do send these reports out every Wednesday to representatives of USET member tribal nations, such as tribal leadership and health directors, as well as our USET staff. For member tribal nations, this aggregate report is also sent alongside a tribe-specific report with more detailed information about what's going on in and around tribal nations. So that report does provide more specific information about COVID-19 in the geographic region in which tribal nations reside, as well as at the clinics or sites there. I did want to also mention that these reports can be tailored to meet the needs of tribal nations. So if you would like for us to modify them, we can easily assist with that. For example, if you wanted for us to use a different numerator or denominator for vaccination rates you see, then we can change that. Or if you would like for information to be displayed differently or in addition to what we are already providing, then we can also do that too. So the slide displayed gives you the number of positive test results, the cumulative total of positive test results, as well as a 7-day positivity rate or percent positivity. And this is for the past week of September 28th to October 5th. For the current week, the number of COVID-19 tests at reporting facilities in the IHS Nashville area in the last week was at 106, while the cumulative total of positive COVID-19 tests was at 9,370. And then that 7-day positivity rate at 7.4%. So it's been a good while since our last echo session, but when comparing these numbers to the update I gave in August, it does look like the number of new positives and the 7-day positivity rate have decreased. In particular, the 7-day positivity rate was at 13.5% for the August echo. But as you can see, it has dropped to 7.4% for the current week. In the more recent weeks, COVID cases have been dropping, and this will be more evident on subsequent slides. What we do know is that with the percent positivity dropping, there has definitely been less of an abundance of positive test results and more of an abundance of negative test results. And that observation also leads me to say that we have likely reached our peak for this most recent wave due to Delta. And so now we are seeing some drops in cases. So the graph shown goes into greater detail about the number of new positive COVID-19 test results, and it gives you a week-to-week comparison of those numbers over a 12-week time frame. So with this, you can really see that we have been on the decline in the recent weeks since around mid-September, where we saw 305 cases. This was mentioned on the last slide, but for the so yes, I did mention this on the last slide, but for the current report week of September 28th to October 5th, the number of new positives in the USET region was 106. And it looks like 335 cases was the maximum number of cases seen during this 12-week time frame. Please note that these numbers are based on the 31 sites in the USET region that are currently reporting cases to IHS. We do know that a lot of influxes in cases were likely due to gatherings where transmission was more likely to occur, as well as the Delta variant, which has shown to be more transmissible than the previous dominant strain that we had circulating. It is my hope that we continue to stay on the decline, although only time will tell at this point. That being said, I think we should still really make an effort to continue prevention measures that have shown to be successful in slowing the spread of the virus, washing your hands, wearing your mask, and social distancing. So this graph displayed gives you the rate of new COVID-19 cases per 10,000 by USET counties, USET states, and then the United States. We also have a 12-week time frame here to reference. Do please note that this data is specifically obtained from CDC and state health departments, and so it's not limited specifically to tribal citizens. Although it may not directly be reflective of what's going on at tribal nations specifically, we have continued to find this information useful. It's been a pretty good indicator for what's going on in and around the USET region and tribal nations. And it can also be used to kind of drive decisions related to public health in tribal communities as it relates to COVID-19. So for the USET PERCTA and USET state portion of the graph, we are looking at the weeks from mid-July to a little after mid-September. Please note that the data points for the past 2 weeks for the PERCTA and state rates have been removed for data cleaning purposes, so those are not available to reference. Although we can reference previous weeks, and we also have a full 12-week time frame to look at for the USET US rate. My apologies. So I also want to note that the PQC for the USET state rate, that 81.90 is most likely due to backlogs in various states tracking and reporting processes, or just simply not updating case information. As a negative state rate was observed the week prior to that, which is not displayed and has also been removed for data cleaning purposes. But again, with this graph, you can see that cases are decreasing in the recent weeks, which is nice to see. And so for the USET County and USET PERCTA rates for the week of 9/14 to the 21st, those were reported as 22.99 cases per 10,000 for the USET counties rate, and then 22.53 cases per 10,000 for the USET state rate. Looking at the most current week of September 28th to October 5th, you can see that the United States rate was at 22 cases per 10,000. So again, cases are decreasing across the board as we seem to be coming down from our peak here. These next few slides will cover graphs that showcase the vaccination data currently included in our weekly surveillance reports. It is our hope that you found this information to be beneficial thus far in tracking the progress made with vaccine administration at your tribal nation, as well as in your geographic area or region. Booster dose administration is now underway, but at this time, we do not have information available to report on, although I assume that we will be incorporating this into our future reports. I do have booster dose data that I pulled from CDC available to share. So according to the data tracker, 3.6% of those fully vaccinated in the United States have received a booster dose of the COVID-19 vaccine. And so, as I mentioned before, we don't have that booster information available for the USET region, but the slide currently featured does give you the percentage of population fully vaccinated, broken down by reporting facilities in the IHS national area, the United States, and then the Indian Health Service, or IHS. Please note that the bar for the reporting facilities in the IHS national area is reflective of a total of 17 sites that have been conducting COVID-19 vaccinations in the national area or USET region. And these graphs are displaying numbers from the previous week of September 28th, and then for the current report week of October 5th. So for the past week, the percentage of population fully vaccinated for the USET region was at 45.7%, while the US rate was at 56%, and then IHS at 36.1%. I'm happy to report that we have seen continued progress made with vaccine administration nationally within the IHS area and the USET region. Although overall, and I mentioned this on my last update, vaccinations have slowed down or plateaued, but it is nice to see that the US vaccination rate has surpassed that 50% mark. This graph also provides information on the percentage of population fully vaccinated, but instead it's being broken down by all USET states, the United States, and then again, reporting facilities in the IHS national area. From this visual, you can see the percent increase that has occurred from week to week. When looking at the percentages for individual USET states, it appears that they range between 43 and 69% for the current week, with about 0.2 to 1% increases seen from the previous week. This supports the statement that I said about COVID-19 vaccination slowing down as a whole, as earlier this year, we were seeing 1 to 5% increases from week to week. But it is clear that we are still making progress. So that is something that should be highlighted, and wonderful job. And thanks to all of those who have supported and worked in the COVID-19 vaccine effort. I also wanted to go over this one last slide, which also covers vaccine administration data. It provides you with the percentage of delivered COVID-19 vaccination doses that have been administered. This information is broken down by the United States, USET states combined, and then lastly, individual USET states. And these percentages demonstrate that for this past week, a good job was done in getting the vaccine that has been delivered to states administered to the public, or needles to arms per se. And so when looking at the USET states in particular, it does appear that a great job was done this past week in doing so, as the percent is pretty close to the United States percent. I wanted to end by saying, as always, please feel free to reach out to the USET tech team if you have any questions or concerns related to COVID-19, as well as anything that is outside of that. We'd be happy to assist with any technical assistance or questions that you do have. And our email address listed on this slide is usetepi@usetinc.org if you would like to get in contact with us. With that, I would like to say thank you for your time today, and I'll take any questions at this time. And if not, then I'll pass it on to our next presenter, Dr. Mira.
Thank you, Imani, for a great presentation, as usual. Do we have any questions right now for Imani or the EPI team? You can type them in the chat box, or you can unmute yourself and ask. Hearing no questions. we can move on to Dr. Mary's presentation. Sorry.
Give me 1 second. Let me.
Sure.
Can you see it there? Or
We see that presenter view.
yeah, let me swap that. Is that better?
Yes.
Okay, thank you. So I'm going to be covering 2 topics today, as Brian mentioned. The first one is booster vaccines, but and then monoclonal antibodies. Before we could dive into the booster specifically, let me show you a couple of reports that can give you some idea of why this is happening. So this is a study that looked at durability of immune responses to the Pfizer vaccine. And what they did is they looked at not only antibody, but also T cell responses, although I'm going to focus on the antibodies. And they tested it against the original variant, the Wuhan variant, and they tested it against several other variants. And the conclusion of the study was that there was a substantial waning of antibody responses 6 months after the patient got the second dose of the vaccine, and also on T cell responses. And the authors suggest that due to this information, boosters would be recommended. And here you see 2 graphs. The left is females, the right is males. Each dot is an individual patient. You can see on day 0, they get their first shot, and day 21, they get their second shot. And you can see how the neutralizing antibodies start increasing, but over time, they start coming down. At around 6 months, they are low, and some are even undetectable. And when you look at males, same pattern, that they seem to have a little bit more robust response than females, but the pattern is you peak at 2 months, and then your antibody levels of neutralizing antibodies come down. When they tested the same concepts, but for the different variants, including the Delta variant that you see here, you can see that at right after 2 months, almost 2 months, 42 days after immunization, the antibody levels are high, and then 6 months later, they're low. And that happens with each variant that has been plotted in this graph. You can see that some variants have a better response than others, but overall, the pattern is very similar. You peak at 2 months, your levels come down at 6 months. Switching gears a little bit, this is a CDC report on safety of the mRNA vaccines. And this is based on the vSafe. When you get your vaccination done, you're asked to download an app, which is called vSafe. And then they ask you questions after several days and weeks after you get your shots. And these questions are relating to side effects or how you're feeling, etc. And when they noticed as that after the 3rd dose of vaccine or the booster, I'm not sure if these 3rd doses were boosters or additional doses, but for this purpose, it's the same thing. 79% had local symptoms, 74% had systemic symptoms, which is very comparable to the symptoms that you get after your 2nd dose, 77 and 76%. And in this graph here, you can see a little bit better. Each column is symptoms after the first, second, and 3rd dose. You can see that between the 2nd and the 3rd dose for the Pfizer vaccine and for the Moderna vaccine, the columns are very similar. So their conclusion is that this appears to be there's not any major differences in safety between the 2nd and the 3rd dose. Now, having said that, what are the problems with these 2 studies I presented so far? The first study, it's only laboratory studies. They're not correlating a booster dose or, well, the first one didn't have a booster dose, but they're not correlating this with real clinical outcomes. And this second one, this is outer reported. And this is biased because the patient reports their symptoms if they want to. And they can download the app if they want to. So you're selecting a very specific population. And then, we've been concerned about side effects of vaccines. So far, the major ones in males have been myocarditis, and in females, the strokes with specific vaccines. So this study looked at myocarditis, and this is a pretty big study done in California by the Kaiser Permanente group. And they looked at number of myocarditis that required hospitalization in a certain period of time. And they looked, were the patients vaccinated or not? And then what they found is that during a 6-month period, there were 15 cases of myocarditis among over 2 million people that were vaccinated with either one dose of the Pfizer or Moderna vaccine. And when they compared it to non-vaccinated individuals, it was a little bit higher. So the relative ratio of myocarditis in vaccinated versus non-vaccinated individuals was 2.7. Still, it's a rare phenomenon, probably more associated with the vaccine. There's no causality yet established as far as I know. And the groups of people who got the myocarditis were usually males that were younger than 40 years old. The good news is that they were all discharged from the hospital. Nobody died. So it was not a significant, it was a serious side effect because patients were hospitalized, but it didn't have a bad outcome. So what the authors also mention is that although this is rare and mild, maybe I would argue with the mild, because if you get hospitalized, that becomes, for any clinical, if you're doing a clinical trial, if you get hospitalized, that's a severe adverse event. But the myocarditis in itself was mild, and the patients were discharged. But when you compare this to patients with COVID-19 who are hospitalized, 28% of them have myocardial injury. So if you're, everything in life, it's a choice between pros and cons, or, complications and benefits. And if you get COVID-19 and get hospitalized, you're going to end up with heart problems much more frequently than, a couple of cases in a million of vaccines. So that shouldn't be a barrier to getting vaccinated. Okay, let's go to booster vaccines. So the FDA and the CDC recently came out with recommendations of a booster vaccine. And who are they recommended? First, only for Pfizer vaccine. No recommendations yet for Moderna or the Johnson & Johnson vaccine. And the reason is because they apparently have more data with Pfizer than with the other ones. The indication is to be given 6 months after the second dose of the Pfizer vaccine. And who would qualify? Anybody who's 65 years old or older, anybody who's 50 years old or older, but has a risk factor for progression. And then if you're less than 50, but have comorbidities or risk factors for progression, you can have it if you want to. It's not a strong recommendation, but it's not a contraindication. And also adults who are at risk of exposure because of their occupation, like healthcare workers, for example, or anybody who's living in congregate situations. Examples would be army barracks, for example, or other people with high exposure, in my opinion, could be teachers. They're exposed to a lot of kids that are not vaccinated, et cetera. But it's important that this is only for the Pfizer vaccine. And I'm not going to go through this list, but just these are all the comorbidities that qualify you for a vaccine if you're older than 50, or even if you're less than 50, but you want to get it. So, and basically any chronic condition, and here on the left are some more specific conditions. And there's less information on these 4 conditions, but they are part of the qualifiers: asthma, hypertension, immune deficiencies, and liver disease. Okay, so the question is, to boost or not to boost? So I would like that those who are I wouldn't say in favor or against, but who feel confident on boosting, to put it on the chat, put a yes. And if you don't feel confident, put a no, if you want to. This is voluntary. You will not get graded on this. Okay, so let me be the devil's advocate here on boosting and give you the reasons why maybe we should think about this a little bit more. So what is the problem that triggers consideration for boosting is the Delta variant. So all the vaccines were studied with previous variants. We had good responses, but now we have a new variant going around that apparently is causing a lot of problems and even infections in people who are vaccinated. So the idea of boosting is to increase your immune response to the vaccine by adding a third dose. And hypothetically, that would protect you, give you more protection against the circulating variant. So what actually should be done is the decision should be based on evidence-based information and consider benefits and risks, not only for the individual, but for society. For example, let's say that there was really good data that boosting helps, but if it helps a few people and you are diverting vaccine for boosting to a lot of people when a lot of people haven't even had a chance to get a vaccine, that would not be a society favoring decision. And all these decisions should be informed by reliable science more than politics. The information I'm presenting you came from a group of scientists, mainly from WHO, but several from the US and ex-FDA people. So what do we know? I'm sorry. What do we know about observational studies that have been done so far? Because I want to clarify one thing. The randomized controlled studies were done with vaccines for the first and second dose, or first dose if there was only one dose, but there's no randomized controlled studies that have been published yet for a booster dose. So all the studies that suggest boosting come from observational studies. The observational studies that we have so far say that the COVID vaccines continue to be effective against severe disease, including the Delta variant, and that most observational studies on which these are based are preliminary and sometimes difficult to interpret. And even if boosting were eventually shown to decrease the medium-term risk of serious disease, current vaccine supplies could save more lives if you assure that people who are not vaccinated get the vaccine and not divert vaccines for boosters. Now, I want to make one clarification. This is looking at the worldwide picture. I don't believe that in the US, there's a lot of people who don't have the vaccine because of access. There might be some, but I think most people have access to the vaccine. In the rest of the world, though, the majority of the non-vaccinated are because they don't have access to a vaccine. So what are the pros and cons of boosting? So the pros that boosting could be needing is for individuals in whom the primary vaccination might not have induced adequate protection. Some use a different terminology, not boosting, but additional dose instead of a booster dose. But at the end of the day, it's a third dose. So for example, if you got a vaccine that has less efficacy in the United States, that's a little bit arguable because of the three vaccines, the RNAs are very comparable, and the Johnson & Johnson, it's a little bit less, but they have not been compared head to head. So it's difficult to say that it's less efficacious. But there are 17 vaccines worldwide, and some are less efficacious than others in other countries. Or if you have an immune compromised individual in which we know that like transplant recipients, especially kidney transplants, they have a 40% response to the 2 doses, but you give them a third dose, and that goes up to about 60%. Now, in the general population, the argument to doing a boost is what I mentioned in the first studies that I showed today, is because immunity goes down, and neutralizing antibodies and T cell responses, when they were measured in those studies, they decline with time. Or the other reason could be that the variant that's circulating right now is not protected by the vaccine that we have available, and that would make you want to give a booster, but the booster should be with the new variant information, not with the old one. What are the cons? Well, you may say people do not respond well to 2 vaccines, but they may not also respond to a third vaccine, and that happens in other vaccines that we know of. For example, hepatitis B, giving a second round helps a few people, but most of them do not have a response. Here we know that it helps a little bit in some transplant situations, but we don't know this in the overall population. And it is not known if it's more beneficial when you're boosting to use the same vaccine that you were using before or to switch vaccines. And there are some studies that suggest that using, for example, AstraZeneca and then Pfizer is better than using Pfizer and Pfizer. But all that data is still not out there. And even if humoral immunity appears to wane, a reduction in the titers that we're measuring has not been correlated with higher levels of infections. So we need that clinical correlate to make sure that, for example, it has been shown that hepatitis B vaccination, even when once you've responded to the vaccine, even if you have undetectable antibodies, you're still protected. So we don't know this with the COVID vaccines. The important thing is also that we know the side effects, like the myocarditis that I showed you recently. We know what happens with 2 doses. We don't have data with a booster dose. I mean, especially if some of these complications are autoimmune mediated, maybe a 3rd dose of vaccine could generate more complications like myocarditis or Guillain-Barré. And the authors conclude in this part that if unnecessary boosting causes significant adverse reactions, there could be implications for vaccine acceptance that go beyond what we've done so far with COVID-19 vaccines. So this is a very interesting graph. It takes a little while to digest, but let me walk you through it. So they compare, the y-axis is efficacy of the vaccine against severe disease, and the x-axis is efficacy of vaccine against just getting infected. And on the left upper corner on A, this is vaccine efficacy against any infection. So you can see, I drew this red line to cover the 90%. You can see that against any infection, most of 15 of these studies showed that it was above 90%, but when you add another 13 studies, they're around 80%. And the worst comes to worst is 75% protection against any infection. But when you look at severe disease, they're above 85% and even 90%, depending on which study you look at. When you look at against different variants on B, look at the Delta variant, we still have protection against severe disease for more than 90% of the vaccinated people. And we still have about 80% protection for infections. And when you look at the type of vaccine, the mRNA vaccines are still offering you more than 90% protection against infection and 90% protection against severe disease. And when you look at early protection versus late protection in time, because some studies have measured this like 2 months after vaccination or 6 months after vaccination, it still is pretty comparable. Late, it's a little bit lower than early, but still above 90% for severe disease and above 80% for early disease. So what do we know so far? Summarizing a couple of these studies. So findings from randomized trials have been done for the 1st and 2nd dose, and they show that these vaccines are very efficacious. But there are no results from randomized trials looking at boosters yet. I mean, I'm sure there are ongoing, but we don't have any final results. So what we have is observational studies, and some are peer-reviewed and some are not. So there are problems in interpreting the results of these studies. And what have these studies shown? That vaccine efficacy is substantially greater against severe disease than against any infection, and that vaccination appears to be substantially protective against severe disease from all the main variants that we've been observing, and that there is still high vaccine efficacy against both symptomatic and severe disease due to the Delta variant. And this is just with the normal, 2 doses of vaccines. So the current evidence does not appear to show a need for boosting in the general population. What are the problems in the interpretation of these observational studies? Well, first, when you're looking at observational studies, the estimates may be confounded by the characteristics of the patients and how you're mining the data. Remember, on a randomized control study, you're in control of all the data of those individual patients that you're including in the study. When you're doing these observational studies, you have to mine EHRs and you make assumptions. So if you don't find someone that had a vaccine given, you put them on the non-vaccinated group. But actually that person could have had COVID and have antibodies and they have certain protection, or could have been vaccinated and that documentation is not in the electronic health record. So there could be mistakes of that nature. Also, when you're doing observational studies and you're looking at the outcome of infection, infection is only diagnosed by a test, and vaccination status can influence the frequency of testing, or even if you want to get a test. Maybe because I have the vaccine, I want to get a test if I get a symptom, or vice versa. So the outcome results are a little bit muddied. Now, observational studies are particularly useful when looking at severe complications, because you may choose to get a test or not if you have a runny nose, but if you're hypoxemic, you don't get to choose if you stay at home or not. You end up in the hospital and you end up in the ICU. So observational studies of severe outcomes are probably a little bit more reliable. And so far, they say that the vaccine, the 2 doses that we have of vaccines are protective. And I can not only vouch for this by the literature, but when we look at this last surge here in our hospital, 95% of the people who were admitted in the hospital were not vaccinated. Only 5% were vaccinated, and of those, many of them only had 1 dose of the vaccine on board. So when you look at the studies in which the boosting has been, the studies that have made some scientists or regulators or people from CDC or FDA or whatever recommend the boosting vaccine. The study that was done in Minnesota that looked at hospitalizations and said, oh, in July, there were more hospitalized people than in January. When you looked at the confidence intervals of those studies, they were very wide. Then even in Israel, they had a little bit in which most of the data comes from Israel. They saw that reported effectiveness of against severe disease was lower in January or April compared to February or March, which doesn't make really much sense. And then the main report, in which I think triggered the recommendation of boosting, only looked at a very short follow-up, 7-day follow-up. And that does not mean that boosting will give you a long-term protection. It just means that they looked at it within 7 days. Then when you look at the studies done in the US, what they do demonstrate is that the vaccines protect you against severe disease very well. And although it might be a little bit less against infection, vaccines are actually designed to protect you against severe disease. That's the mainstay of them. Okay, so kind of wrapping up with boosting a little bit, the message that boosting might soon be needed, if not justified by robust data and analysis, could adversely affect confidence in vaccines and undermine messaging about the value of primary vaccination. So that's why they're recommending that not only you look at the data, but also that look at all the vaccines that we have available, because giving out the information of, oh, only get boosted if you got the Pfizer vaccine, that generates a little bit of anxiety and confusion. So it'd be important to have information on all the vaccines to see if they do need boosting or not. And then we need to define, if we're going to boost, are we going to boost with the same antigen that we were using, or the same RNA sequence or DNA sequence, or are we going to adapt it to the new variants? In influenza, every year we look at the circulating variants and we adapt our vaccines to that variant. Why should this be different for COVID? It really doesn't make much sense to boost with an old vaccine if you have the capability, of course, of using a newer vaccine, if a study actually demonstrates that boosting is necessary. So they finally say that vaccines are the ones that we have are currently safe, effective, and save lives, and that the limited supply should be used for vaccinating everyone who hasn't been vaccinated yet, instead of using it as a booster of situations in which we don't really know if it's needed or not, or how safe it is or not. And if vaccines are deployed where they could do the best good, they would hasten the end of the pandemic by inhibiting future variants from appearing. Okay, so I don't know. Let me check the chat. I don't know what, I can't see the chat in the mode I am right now. Okay, let me see. Oh, I can. So don't need to, but wouldn't mind. I have as well. I am on biologics. Yes, yes. And okay, so many people said yes. And I mean, I'm not disagreeing with you. Actually, I would have said yes before I reviewed all this data that I showed you today. But today I'm a little bit more cautious. What would I do if I have a patient that comes and asks? So if the patient is just coming for the booster because they meet the guidelines and they're not asking for advice, I would just give it to them. But if they're asking me for my true opinion, I would take several factors into consideration. I would take their age, their comorbidities, especially if they're a very immune compromised individual. And I probably would, make a recommendation on someone who's immune compromised, but more as an additional vaccine, more than a boosting vaccine, just to see if we can get a response if they haven't got one already. And I wouldn't have a problem in doing on people who are institutionalized, like in nursing homes, or people who are 75 years or older. But if you're a 55-year-old with hypertension and that's all your risk, I would probably say wait until we have more data before you take the vaccine. That would be my recommendation with the information that I have today. And of course, I may change my mind when we have more data. So when we have strong clinical trial data, that could be different. Okay, briefly, let me cover monoclonal. I know we have 20 minutes, but let me cover monoclonal antibodies real quick. So these are the monoclonal antibodies that we have available in the market. The first three are for outpatient use, and they target the spike. They target the spike protein. The last one, tocilizumab, is only for inpatient use, and they target interleukin 6. The only one that can be given IV or sub-Q is casirivimab and imdevimab, which is Regenco, and all the rest are IV. So these are the indications, and I'm not going to go in detail, but you have to be an outpatient. You cannot be requiring hospitalization, and you have to have high risk as defined by the ones that are listed here that we kind of went over them with the vaccine they're very similar. Now, one add-on, which is important for us, if you don't have any risk factors of the ones listed in the other place, you are still at high risk if you are Native American or individual of color, because they have higher mortality rates. So you could use the monoclonal for someone who has COVID-19, is symptomatic, and they're Native American, then that's it. And that would be okay. So who should not receive it? If you're required to be hospitalized, you shouldn't get it. If you are on supplemental oxygen and you're increasing the need for that oxygen, you shouldn't get it. And those are the big no-nos. The problem is that there is some evidence that when you give monoclonals in general to people who are sicker, their outcomes can be worse. Having said that, there is some preliminary data that with the Regenco that might not be true, but I'm going to stay there and not give you any more information until I have better information on that. So Regenco or casirivimab and imdevimab can also be used for post-exposure prophylaxis. And here are the indications. So if you're 12 years or older and you're not vaccinated, or maybe you are vaccinated, but you are immune compromised and maybe you did not respond well to the vaccine, or you live, for example, in a nursing home and you're very exposed to COVID-19, regardless of vaccination status, and you've been in contact with someone who has COVID-19, contact defined by CDC definitions, then you qualify for post-exposure prophylaxis, and that is another option we have. What is the impact of using Regenco for treatment? And the reason I'm focusing on Regenco is because bamlanivimab is ativimab, and we used that one initially. The indications are exactly the same for Regenco. Then it was halted because of the variants. Now you can use it again because it seems to work for more than 80% of the circulating variants. But the one that we're using is Regenco because we just started using that one, and that one has better data for the variants than the other one does. So it reduces the risk of hospitalization and death by 50 to 70%. Number needed to treat to prevent a hospitalization or death, about 33 to 50 patients. And post-exposure prophylaxis, it reduces your risk of getting COVID by 81%. So that's the reason why it's a useful post-exposure prophylaxis medication. I want to show you a study that was published a few days ago, and this is very interesting because it was by one of our colleagues in, I think it was in Phoenix. So this was the outcome of comparison of high-risk Native Americans patients who did or did not receive monoclonal antibody. And here's the table. And they did a great job because they were able to infuse this drug within 3 days of symptoms for the majority of the patients. But when you look at variables that are not easily confoundable, like getting admitted to the ICU or death, patients who got the monoclonal, there were no ICU admissions and no deaths compared to 12 and 8 on the non-recipients. Now, this was not a case control study, so their control group is not perfect. Actually, they don't have a control group. They compared to people who did not get monoclonals, but they were not matched for that. So you have to have that into account. But nonetheless, I think it's a really good study that shows that at least giving this medication within 3 days, it seemed to decrease, severe disease in these patients. And I encourage you to read it. It's a short article in JAMA. So a couple of caveats on administration of Regenco. You need to do it in an area in which you can address an anaphylactic reaction if it happens. They're rare. We haven't seen any. We have infused over 1,000 patients with this monoclonal and about 1,000 with the other one, and we never had an anaphylaxis. But we did have some people getting some mild discomfort in some cases, in a handful of cases. It's IV infusion, but you can also do it subcutaneously. We prefer the IV because we're already set up for that. And patients can be symptomatic only within 10 days, but the sooner you give this, the better. And the infusion takes about 21 minutes, but you have to observe the patient for about an hour. So that's the problem. Sometimes you have to have space and capacity to observe the patient for an hour. We have one person sitting in front of all these little tablets. Each tablet is connected to a room. Now we have a cohorted room, and that observer is just watching people, making sure they're doing okay. The adverse events, the major potential one is anaphylaxis, and that's why you have to have a crash cart and be prepared. And the ones on the right are the most frequent, cited side effects. In our experience, what we see sometimes is vagal reactions, but it's usually because of the IV more than the drug itself. But the majority have been, reversible, and it's been very few patients that we had to stop and not continue with the infusion. So mandatory requirements by EUA, only use it for the indications that it's listed. Give the patients the fact sheet. You have to inform them of what you're going to be doing and give it to them by writing. Tell them that if there's any alternatives to this treatment, you should offer the patient the alternatives. Right now, really, the only alternative for patients is monoclonal antibodies. Soon we'll have some antivirals available, but right now there is no other alternative except, just supportive care. And this is very important. You have to report any severe adverse events within 7 days to the FDA. And that's your responsibility to do that. So these are just some tips on the administration of it. It's got to be diluted in 100 mLs of normal saline. You infuse it over 21 minutes. You do need a filter for the infusion. That's the only major difference from any other infusion. You need to observe the patients for an hour, and you need to monitor their vital signs and symptoms and document the infusion. Have good documentation of what you're doing. And one more thing, the providers need to document that they gave the patient the information on the fact sheet on their notes. And this is just a final summary of the 5 steps. Make sure the patient meets criteria. Make sure that you give them all the information. Determine if you're going to use the IV or the subcutaneous route. And if you cannot administer the monoclonal, refer the patient to a site that can do it, and share your educational resources with the patient and your peers. And that is it. I hope I didn't put you all to sleep.
Not at all. Thank you for a great presentation, Dr. Mira. Do we have any questions at this moment for Dr. Mira? You can unmute yourself or you can type in the chat box, whichever you prefer. There are some questions, sorry, in the chat. And it deals with the booster. I think they all deal with the booster. So the first one is, would you let the patient pick which shot they get? You're on mute.
Can you repeat the question, please?
Would you let the patient pick the shot they get?
For a booster dose?
Yes.
Okay, no, right now, no. Right now, the FDA and the CDC recommendation is Pfizer. You have to have had Pfizer as your first 2 shots, and you can give a Pfizer third shot. If you had Moderna or J&J, you're not allowed to give a booster of those vaccines. Now, the reality is this. Any patient can get it if they want to. They just choose a pharmacy, go and say whatever, and they'll get the vaccine. I mean, there's really not a barrier to do it, but it is not a recommendation.
Next question in the chat is, what about occupation? You had mentioned that.
Well,
this
okay,
time you
so
would
the
recommend.
bottom line is this. We don't have a randomized controlled study that randomized people who had the full vaccine. So everybody should have had, the complete series of their vaccines. Call it Moderna, Pfizer, or J&J. And then you would have to randomize these people to, I'll give you a booster, or I'll give you a placebo shot, right? And then you look at outcomes like they did originally, and you look at number of new infections, severity of infections, et cetera. And after you get those results, you say, well, the boosters did prevent hospitalization, so it's recommended. And then you do sub-analysis and say, okay, within the patients that it protected, was there any subgroup that had higher protection, like transplant recipients or school teachers or healthcare workers? That's the way this should be done. It hasn't been done that way. It's been rolled out massively in some countries like Israel, and then they look at the data and it's an observational study. So having said that, my best answer is I don't know. I mean, I can just give you my gut feeling. So my gut feeling would say that I probably would recommend it to any immune compromised individual, either immune compromised by disease or immune compromised by medications, especially if they're concerned, okay? And if I'm gonna choose people who are heavily exposed, I probably would choose healthcare workers and choose teachers or any situation in which you would have people that are in conglomerate situations. But also that they have high risk, because if this is a 20-year-old healthy teacher, although you have a high risk of exposure, you don't have high risk of progression. But if this is an obese teacher with diabetes and 65 years old, that's a different story, right? So I think I would do it on a case-by-case basis, but at the end, telling the patient this is based on not good data, just observational data. If I would know that the vaccine is completely safe, that third dose, completely safe, I would be more lenient in giving it to everybody who wants it, right? But I'm not sure of that either. We don't have data on myocarditis after booster dose. We don't have data on Guillain-Barré after booster dose, on autoimmune hepatitis after booster dose. So I'm not sure if by recommending it very strongly, I'm putting that patient at more risk than benefits. So at the end of the day, if they're a very high risk patient in a very high risk situation, that's the one that I probably would recommend a booster dose. I will give you my experience. I was scheduled today to get my booster dose. I'm not getting it today. I need to think about it a little bit more. I mean, I have some risks. I'm a healthcare worker, and I'm not going to disclose all my private medical information, but I do have some risk factors, but not enough to warrant me to get the dose. And I'm thinking about it. Probably wait a little bit until I have more data to make sure that I need it.
Okay. The third question is very similar to Actually the same as the second one. So we'll move on to the last one. Do you recommend that individuals continue with the same vaccine such as they received Moderna to continue with Moderna?
If they get a booster dose? Okay, that's a very
We do.
interesting question. And actually, there is some data, not on boosting, but on just initial vaccination schedule. Because some countries, what happened is they got donated Moderna, right? And the first dose was Moderna, and they ran out of it. And then came the Sputnik came, which is a Russian vaccine, and that's all they had, and they just gave that one. So that has been in the States. That has not happened too much, only by accident maybe, but in other countries it has. So there are some studies that are ongoing to look at that. And the few data that I've seen is that it may be more beneficial to switch vaccines because you get a better immune response. But please don't take that as a recommendation. That's just some data that I've seen. I think there are studies that are ongoing looking at that question, and we'll have more information in the future. For now, I would say stick to the same vaccine because that's what we know best. And when we have more information, we can make different recommendations.
Do we have any other questions for Dr. Mira? You can unmute yourself or type in the chat box.
And while you're thinking of the question, what I strongly do recommend is use the monoclonal antibodies. The data is very robust from randomized controlled trials and even the observational one that we just saw. But you have to do it quickly. Do not delay treatment. I mean, the sooner you give the drug, the better the outcome of that patient.
I don't hear any other questions. Thank you again for a wonderful presentation, Dr. Mira, Imani as well. Emily, you have a question or two?
So I don't have a survey today, but in an effort to get everybody to participate, I was wondering if you could just drop in the chat or say out loud what topics you would like covered in future COVID-19 echoes. Or you can always email us any other time.
Right. You can email Emily at efield@usetinc.org. You can email myself at bhendricks. I'll put it in the chat. bhendricks@usetinc.org, or you can email the EPI team at usetepi@usetinc.org. I put an extra period in there, sorry.
Okay, maybe the 6 to 11-year-old vaccination. I'm guessing there'll be another update on boosters in a month too. I would hope.
Yeah, we definitely should do a booster update when we have more information.
Definitely. Definitely.
Adverse effects, yeah, that's a good topic. We could try to summarize that, and of all the side effects.
Well, thank you, everybody.
Bye-bye, thank you.
Thank you all. Have a great weekend.